Lower leg fractures are going to include fractures of either the tibia or the fibula, or you may have both of those fractures occur simultaneously. When we classify fractures, they are classified by three areas. First, we look at the fracture location. We want to make sure whether or not the fracture occurs at the epiphysis, specifically that epiphyseal growth plate. We may see a fracture in the metaphysis. We may see a diaphysis fracture, or it may also be intra-articular. Obviously, each of these end up with their own problems depending on where they are, and again, depending on the two other forms of classification. The second being the severity of the fracture. We can have an incomplete fracture, which may be something that we see with a green stick fracture where it hasn't completely severed the bone. We can have undisplaced fractures, which we're hopeful for because those generally are not going to require any type of surgery. But then we can see a displaced fracture, which will require some type of surgery because they will have to realign the bones generally. And then an open fracture. And the open fracture obviously is one that is coming through the skin. The third type of classification that we look at is the shape of the fracture line. And there are a lot of different shapes that you will see, such as maybe a depressed fracture, which is something that you could see maybe in a skull because of the shape of the skull bones. Transverse, running across the bone. You can have the comminuted fracture, which is kind of a crushing type fracture, so you end up with a lot of different pieces. There can be spiral fractures, which occur when you've got some type of twisting that takes place. Spiral fractures are often seen in skiers because their ski boot holds the leg in place. There can be longitudinal fractures, and then the green stick fractures, which are fractures that you will see in younger athletes and patients. We all can pretty much guess what the mechanism of injury is, but the mechanism of injury is going to be some type of high injury impact, whether it be, as you can see in this picture, an impact that is indirect or you don't have anybody else involved, or you can have that direct impact with another person or some other type of structure. Signs and symptoms are going to include localized edema, discoloration, a deformity that you may or may not see. It always makes it a lot easier when you can see the deformity. The person will have point tenderness around the area. If the person lets you play with it and test it, you may have some type of crepitation in the area. One thing that you have to keep in mind, if the fracture is only to the fibula, the person may be able to bear weight because the fibula carries such a low percentage of your body weight. Range of motion, obviously you're going to see a decreased range of motion at any of the adjacent joints. Generally, this is due to muscle spasm and involvement of that joint. You may also notice a quasi-joint, and a quasi-joint is kind of depicted in this picture here where you've got a joint where there shouldn't be a joint, and so usually that's going to be in the diaphysis of the bone. The special tests that you're going to use are going to be the bump test, which can irritate the tibia, the squeeze test, and the tap test. And the tap test tends to work really well if you are looking at the distal part of the fibula. Diagnosis is going to be done through an x-ray, potentially a bone scan, but usually an x-ray is going to be able to pick up that fracture. But it often needs to be read by a radiologist because doctors aren't always going to pick up those fractures. Treatment is going to depend on whether or not the fracture has been displaced. An undisplaced fracture that has proper bone alignment will probably just require a cast. If there is a displaced fracture, we can have a stable reduction take place, which can then just be casted. But if it's an unstable reduction, you will see a surgical fixation and casting that takes place. Prognosis is going to depend again on one of the classifications, whether or not it's a closed fracture or an open fracture. A closed fracture is going to be somewhere between 6 to 8 weeks, but it can go up to 17 weeks for the full healing process to take place. An open fracture can take as much as 22 weeks. There are many complications that go along with fractures. And a lot of times we don't even think about the different things that can occur. But you can see from this list, there are several different concerns that we need to keep in mind. For example, if we have a lot of swelling in the area and a cast has been put on the fracture, we can end up with a compartment syndrome. If it was an open fracture, there may be an infection in the area of that fracture. And the infection doesn't have to be just because it went through the skin. The bone itself can become infected as well. We could have a delayed union or non-union. RSD refers to reflex sympathetic dystrophy, which we'll talk a little bit more about at another time, but that can be a concern. And obviously, if you're working with adolescent athletes, an epiphyseal growth plate disruption is something that we need to be concerned with. When we think about the bone and the healing process, it's much more simple than what we see with other types of healing processes or injuries. In the healing process itself, all tissues heal by forming scar tissue, except for bone. Bone actually heals by forming more of itself, which is pretty fantastic. When we take a look at the stages of bone healing, there are 3 stages of healing, just as you would see with other tissue. In stage 1, we have the stage of inflammation. During this stage, you will see a formation of a hematoma. This is due to the infiltrations of leukocytes, macrophages, and mast cells that come into the area. The periosteum becomes stripped from the ends of the fractured segments. This stimulates proliferation and growth of osteoblasts. Stage 2 is the stage of soft callus. During this time, the fibrin network becomes organized and becomes reinforced by collagen fibers. We will see budding capillaries so that we can get more blood flow to the area. Those osteoblasts form fibrocartilage matrices. We will refer to those as osteoids. And then that osteoid calcifies. Usually this occurs about 2 to 3 weeks post-injury. As the osteoid mineralizes, the fracture becomes very securely cemented with parent bone to help keep that bone in the correct alignment. The final stage is the stage of bone healing, and during this stage, the osteoclasts remove immature woven bone, and then the osteoblasts lay lamellar bone to help improve the strength of the bone at that fracture site.